This meeting is now being recorded.
Well, good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program for those attending for the first time. So we're going to go over who we are, what is our program, some upcoming events, introduce our speaker for this evening, Dr. Neilson, and then we'll have a Q&A session. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 60 groups to date. Each group is given their own free web pages with a link from the directory and the map. Last month, we attended as a sponsor of the EDS conference for the third time. There was a great response for our program. We added a number of new EDS support groups in the U.S. We have 2 in Australia and 1 that's upcoming in New Zealand. So we received feedback that conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Wednesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our site at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Score, where you will find over 250 products selected for EDSers by EDSers. The store is the only funding for our program, and it usually covers our monthly web fees. So please visit the store and check out the helpful products that we sell. So just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 and get the services that you need. Always consult your doctor before making any changes to your treatment.
Our upcoming events, our speaker for August 20th is Dr. Posinki. His presentation is titled, Breaking the Cycle of Chronic Pain, Poor Sleep, Depression, and Fatigue in Ehlers-Danlos. Our speaker tonight is Dr. Neilson. His topic is about proving what is obvious to everyone attending tonight. He will discuss what is needed to change the perception of EDS hypermobility type. Dr. Neilson's certifications include the American Board of Medical Genetics and Clinical Genetics and the American Board of Pediatrics. He was one of the first residents in a combined pediatrics and genetics program in Cleveland, Ohio. And after his residency in Cleveland at Rainbow's Babies and Children's Hospital, he stayed at Case Western Reserve University and the University Hospitals of Cleveland. In 2008, Dr. Neilson joined the team at Cincinnati Children's Hospital Medical Center. And in 2012, he took on a leadership role in the hospital's connective tissue clinic and has become well known in the region for his EDS expertise. Dr. Neilson is one of 2 doctors who care for approximately 900 Ehlers-Danlos patients at Cincinnati Children's, and the clinic sees both children and adults. Just a reminder, after the presentation, there will be an opportunity for Q&A. Please add your questions at any time during the presentation by clicking the Q&A icon located at the top of your screen. After typing your question, click the orange button to submit. Well, this time I'd like to welcome Dr. Neilson. We're looking forward to your presentation. And you will see your slides are loading on the screen, and I'm going to turn over the microphone to you now.
Well, thank you very much for that very nice introduction. This is the first webinar I've given, and it's a little bit different. It gives me sort of the surreal experience of talking to my television, which might normally happen on any given day, but it's a little different when there's a potential that it might talk back eventually to you. So this talk is called Proving the Obvious, Next Steps for the Demystification of Ehlers-Danlos Hypermobility Type, and unfortunately it's kind of an unwieldy title, and it seemed like a good idea when I first came up with it. But I think the problem is the demystification is a very accurate term because Ehlers-Danlos really gets shrouded in this veil of mystery, and it's physicians and patients alike really just don't understand what this is all about. Let's see. And I'm going to take a quick pause here because John, I don't see my little box that allows me to change this. Here we go. And I will also show my cursor here. Okay. So one of the problems is that doctors just really don't know much about this disorder. And where does this problem come from? Well, in my medical school, which I graduated in '98, there was maybe one slide in about 4 years that mentioned Ehlers-Danlos. It was really in the context of there are connective tissue disorders, collagen can sometimes cause problems, but nothing was said about the various sequelae that could come from it. Then in my genetics and pediatrics residency, which ended in 2003, the standard line was that, yes, there are some patients with Ehlers-Danlos and they might get arthritis when they are older because of the joint instability, but that was really about it. And this whole idea that there could be chronic pain and other problems just really was not made known. And this was, my training as a genetics resident and going into that field. And so the education of medical providers is very slow and it's behind on this whole issue. And one of the problems that we're facing is that not only is this really not in the medical education, but we're facing a lack of really good educational materials. And what we need to have are educational sources that are accessible, credible, and acceptable. So there's a lot of information. We see lots of websites out there that talk about this, but those are not considered by physicians as acceptable sources of information. What we need to have are sources that are peer-reviewed, meaning that they've been vetted, that somebody has found that the statements inside are true. But there are other barriers to this as well. And this is one of the barriers. This is a very nice model of Ehlers-Danlos and hypermobility syndrome. And this comes from a well-respected group from Italy. And what it's showing is that joint hypermobility syndrome intersects with a lot of different conditions, including chronic pain syndrome, chronic fatigue, immune system dysregulation, cardiovascular dysautonomia, and all these kind of things. This is a nice model that helps us understand that this joint hypermobility can have pieces of all these other kinds of conditions. The problem with this is that physicians look at this, and this is what they see. It looks like a big mess at the bottom of a garbage can. It looks like you've taken every single syndrome that is difficult to treat and not well understood and thrown it into one thing, and this is what I call the trash bag of this diagnosis. It seems that as the time goes on, more and more things are noticed, and they're simply thrown into the pot. And when that happens, you really begin to wonder, are all these things truly related? And that's one of the biggest hang-ups that doctors have is, how are all these things related to each other? And more so, what do we even do about it? So some of the barriers to acceptance, first of all, there's this perception that Ehlers-Danlos is a rare disorder. And I don't do this a lot, but every so often I go on the internet and I look up various sources, and sometimes I see people's blogs and things like this, and they will say, give statements like, I have a rare disorder, or I have an ultra-rare disorder that nobody understands. And when it's put into that phrasing, that ultra-rare, it makes it really seem to be something that's not only not misunderstood, but something that cannot be understood, and that's a big problem. Second, there's a big misunderstanding of the diagnostic criteria. So the diagnosis is largely still based on the clinical findings, but we get a lot of the doctors who don't understand that. So we see statements coming back like, well, you can't make the diagnosis unless you have a gene test or a biopsy. Or they'll look at the skin and they'll pull it out and it doesn't move very much, and they say, well, your skin's not stretchy, so you can't have that disorder. And neither of those statements are true. And finally, what we have is a lack of pathophysiology, which means we don't have the story that says, starting from collagen, how do all of these problems come about? So how does loose collagen translate into this phenotype? And there are some certain questions where you say, well, wait a minute. We know that some of the nerves are affected. We have patients who have dysautonomia, and that's a nerve kind of condition, right? So how does that work? How does collagen change your nerves? That's a big problem. We need to be able to give that story for people to not only understand, but to accept this. And other problems like anxiety, we know that that's very frequent as well. And if that really comes as having this disorder, then you have to explain that. And so what are we trying to say? Does the collagen somehow affect and change the nature of your brain? Where does this actually come in? So these are some of the things that we really need to work on to help make this disorder understandable and acceptable. So how do we demystify it? Well, as providers, what we see are a lot of patterns that are consistent among our patients. And in fact, I have sort of my list of 7 things that you see in patients very commonly. And usually when I run through those, usually talking about one child or another, then the parent will say, oh my God, you just described my life. So it's a very, these patterns are consistent. But even though these patterns are known to those of us who see a lot of patients, they still are relatively uninvestigated. They are not proven that these patterns actually exist. And more so, what we have to do is prove that these patterns exist and place them into a context, meaning no more throwing things into the big bag, no more trash cans. What we really need to say is, if you are going to make a statement that these two things are related, you need to make a statement of how do you think that they are related. Does one cause the other? Are they both caused by a separate problem that is related to this condition in some way? This context is what we need to develop a model of pathophysiology. So the first thing that I wanted to address is that Ehlers-Danlos is not a rare disorder. And when I say that, I'm speaking specifically of Ehlers-Danlos hypermobile type. There are other types of of Ehlers-Danlos that truly are rare, but Ehlers-Danlos hypermobile is quite common. So the pattern recognition here is that we see a lot more Ehlers-Danlos than we would have expected. So how rare is rare? And the current estimates out there vary widely depending on who you read. So if you look at the Medical Resource Guide on the EDNF website, it will quote that about 1 in 10,000 to 1 in 15,000 people may have this. Other sources would quote up to 0.5 to 2% of the population. And these are based on, quote, professional estimates and extrapolating estimates from other pain syndromes such as fibromyalgia. So these estimates, however, are just that. They're sort of somebody's guess as to what they think it is. So that is not great information. But you can see there's a wide range there. So there have been a few additional studies recently that have been helpful. One is a study from Avon in the UK, which evaluated teenagers over time. And it started looking at age 14-year-olds and they had to have a Beighton score of greater than or equal to 6. And this is good because there are a lot of studies out there that will use reduced criteria, such as down to 4. And when you're dealing with younger patients, that is really kind of inappropriate in my mind. For older patients where we know that mobility declines over time, that may be all right. But when you're looking at kids, you should really be more strict in your definition. So anyway, they looked at children age 14 and then rechecked them at age 17. They looked at 2,900 children, and they were asymptomatic at the time of enrollment. And they found out of that population, 4.7% were hypermobile. When they followed them over the next 3 years, 9 to 16% of them developed joint problems. And I say 9 to 16, that range is there because it was broken down by joint. So 16% would have one joint, 9% would have a different kind of joint. So if you look at those two statistics, then that actually gives you an estimate about 0.4 to 0.7% of that school-aged population were hypermobile and developed joint problems over time. And that gets a little bit closer to what we look at as the definition or a working definition of Ehlers-Danlos hypermobility, meaning that we have a lot of patients or a lot of people out there in the population that we know that are hypermobile who really don't have any problems. And we don't necessarily need to call them Ehlers-Danlos, but when we start dealing with people that are hypermobile and have problems, then we do need to give it a name. So we also turn to a few internal sources to get a better handle on how much Ehlers-Danlos is out there. And one of the tools that we could use is a bioinformatics search looking at just de-identified hospital records from Cincinnati Children's. And we just looked up the number of persons between the ages of 5 and 18 who met hypermobility criteria, and there were 2,700 patients on file. And if you look at the total number of patients in that same age range, there's 526,000. So the estimate from CCHNC is that 0.5%, or roughly 1 in 200 children coming to this hospital have been diagnosed with hypermobility. So far more than you would have expected on that 1 in 10,000. Now, if we just look at our connective tissue clinic data, over the past 2.5 years, we've evaluated 2,200 patients, and these were new patient visits, not the people who were coming for follow-ups. And approximately 95% of them go on to be diagnosed with Ehlers-Danlos. So I'll have to give my disclaimer here. We still have a little bit more work to do on this. What we were evaluating is the number of people referred to our institution, and we actually had to go and do the job of going through all those charts and documenting who did and who did not receive that diagnosis. But the majority of the people that come here are actually well screened in advance, and most of them actually do have it. But if you look at that 2,200 patients, if you say that it's the prevalence is about 1 in 15,000 to 1 in 10,000, that 2,200 means that we've seen about 7 to 10% of the entire Ehlers-Danlos population for the United States. Well, the question is, did we actually see them all? And the answer is no. We actually looked up where our patients were coming from because we could pull the zip codes. And the majority of our patients are local. Approximately 60% of our referrals come from a 30-mile radius. That's that inner black circle there. And 78% come from a radius of 100 miles. After that, the rest of the 22% come from farther away. It sort of tails off the farther you go away from Cincinnati. So clearly, we have not seen the entire population of Ehlers-Danlos that is going to be out there in the United States. And in fact, not only were most of our patients local, but a lot of them came from the same region. And this uneven pattern of referrals was really because there are some provider groups that are more tuned in, and whenever they get their patients, or find patients who are hypermobile, they send them our direction. So we looked a little bit more closely at that area, and we found that, and we restricted our search to just the pediatric population because we know that we're not capturing all of the adults who are out there, but we're more likely to see some of the children. And we found out that there were 86 pediatric referrals, and the population of children in that region was about 38,000. So that gives us an estimate of 0.2%. So that means about, from that catchment area, about 1 in 500 children were referred for the suspected diagnosis of Ehlers-Danlos hypermobility. So how common is this really? The answer is still it's unclear. But clearly, I can say that the 1 in 10,000 to 1 in 15,000 is an underestimate. And the prevalence numbers are still to be determined, but it seems closer to that 1 in 100 mark to 1 in 500 mark. Regardless of how common this is in the population, Ehlers-Danlos is nonetheless a problem or is going to be seen a lot more commonly in the hospital and in the clinical setting. And so when we talk to our pediatric pain management group, they estimated about 40% of their patients were Ehlers-Danlos. That's a large proportion of a single patient population. In another study that was looking at all patients coming into an adult gastroenterology clinic, they looked at 552 people and found that 33% of them met clinical criteria for Ehlers-Danlos or hypermobility syndrome, meaning hypermobile joints plus problems that are associated with it. So this is clearly these certain populations are going to be overrepresented in the clinical setting. So the first thing that I have to say about what do we do to demystify this is stop saying Ehlers-Danlos is rare. And this applies to doctors, patients, everybody. The biggest problem when you say Ehlers-Danlos is rare is that in doctor speak, that's rare means I don't need to think or learn about that. In fact, when I think back to my residency, the quickest way to shut down somebody on rounds when they came up with, do you think it might be this diagnosis, would be to say, that's rare. And so when we say that's rare, that's actually a term that doctors use to say that's not worth thinking about. Even more so, it's not worth learning about. They'll want to send you to a specialist. And right now, there are not enough specialists to take care of this. And even more so, if you say Ehlers-Danlos is rare, then the people organizing their educational courses to teach our brand new crop of medical students this year will just say, it is just not important enough to include in our teaching curriculum. We do not want any of those statements to be true. We really need our regular doctors to be able to recognize and understand this and to be out there on the first line taking care of people. If we're looking at a prevalence of 1 in 100 people, and there are 311 million people in the United States, then we're talking about 3.1 million people out there. I can tell you I'm not going to be able to see those patients all in my clinic. So the next step, we really have to build helpful models. The association models that we've shown you, throwing everything into the same bin, that's a place to start. But what we really need to do is use those patterns to build testable models that imply a mechanism, and that mechanism should then imply an intervention. In other words, if a patient comes into me with a certain problem and I know that they have Ehlers-Danlos, that should cue me in to do this kind of therapy rather than that kind of therapy based on the pathophysiology involved. So I'm going to get into some of the things that we are currently doing at Children's Hospital in Cincinnati. And we decided to look at one of the areas that we noticed, that we've been noticing, which is that the symptoms transition over time. And so these symptoms are age-dependent, and they're also variable. And we have a family of 3 here, and this is 3 generations, grandmother, mother, and son. In the children, what we see is that most of the time we don't have a whole heck of a lot of problems. Now, some of you out there may say, well, my child has a lot of problems, and that really does happen too. But we see a lot of, we get a lot of referrals, and so we are actually able to have that opportunity to see that there are a lot of children out there that have this that are doing fairly well. And so what we notice is that some of them may have more hypotonia when they're younger, but that's not too often. The most common thing that we get are children that have growing pains. Handwriting problems are pretty frequent as well, and a lot of our children will have more frequent bruising and bleeding issues, and that might just mean they have a lot more bruises than their friends, or maybe nosebleeds are more common as well. Occasionally we get children that have the more full-blown picture with headaches, with the dizziness with standing and racing heartbeat, and have more tendency to joint dislocations. but actually they tend to be less common in our clinic than the kids who are just sort of having growing pains. But as those kids get older, we notice that things change. And when kids hit teenager years, we see a lot of problems begin to develop. We see a lot more musculoskeletal dysfunction, which can manifest as chronic pain and joint dislocations. We see more problems with the jaw joint, so TMJ. It's the time when we often see more problem with dysautonomia and the orthostatic intolerance, which is these findings mean that you get dizzy when you stand up and begin to black out and have racing heartbeat. There's more gastrointestinal dysfunction. Chronic headaches begin, and we can see the bruising and bleeding can sometimes get a little bit worse. And we often see more anxiety and panic disorders happening at this time as well. So that pattern recognition says that there are phases to this condition. And in childhood, it's usually fairly mild, and we have a very flexible child. In teenagers, we see two things happen. In boys, we often see things get better over time, and flexibility will decrease for some of them. Not all of them, but many do. In girls, what we see is that there's an acceleration in many. Not in everybody, but in many of the patients that we see, that's really when it begins to start. And so the flexibility at that point is really retained, and sometimes it increases. And what we often see is that the onset of symptoms seems to happen around the same time as menarche, meaning when the periods first begin. And some of our patients will even relate that their symptoms seem to correlate to various phases of the menstrual cycle. And then what we see in adults is that flexibility tends to decline, but there are a lot more females than there are males. And this is very unusual because if we look at the childhood situation, it's really about a 50-50 mix. So one of the things that we wanted to look at was this hypothesis that male hormones versus female hormones will change the quality of connective tissue. And many of us will just say, well, that's just obvious. We know that already. And in fact, there's lots of papers out there that say that ligaments change and there are more sports injuries in girls when they're after puberty and things like that. But what can we really say about our patient population? So have we proven that the hormones are a driving factor that change the symptoms in our patients? And the answer is no, that has not been proven. Now, there have been some papers out there that have suggested that this might be a process, but we really need to hone down on that question and really demonstrate that this is true. So our approach was to start at the place where we might expect to find the biggest change in hormones, which is puberty. And our advantage here is that we have a young population, and we have a lot of children who are prepubertal and a lot who are postpubertal, and some who are going through puberty now. So we did a study, and over 3 months we collected 91 young patients. What we found were about 112 individuals who met the inclusion criteria, and what we used as the inclusion criteria was that you had to meet the Villefranche criteria, which said that you have to have 5 or more hypermobile joints on the Beighton score, and you have to have some evidence of connective tissue laxity. It didn't have to be much. Those signs in hypermobility are subtle, but we had to meet those strict criteria. So because of that, we actually had to exclude about 21 of our individuals. Some of that was because they didn't meet criteria. Some of it was because of other factors, like they didn't fill out the forms completely or some things like that. But we got down from our 112 number to 91, and we divided them into 4 groups. We have the early and prepubertal males, and that's abbreviated EPP, and there were 19. 5 late and postpubertal males, and then 25 early prepubertal females and 42 late and postpubertal females. One of the things that you can notice just looking at that we really could not find a lot of the late or postpubertal males, whereas we had relatively equal numbers of early and prepubertal males versus females. So even at this stage, we were finding that there was a difference in the number of patients we were able to pull out of our referral population. So the tools that we used was we did a study examination, and I underlined that part to remind myself to tell you that was an important piece. There have been a number of surveys that have been conducted through various groups where you a survey gets sent out by mail, you answer the questions and send it back. And the problem with those studies is that you're never really 100% sure how the diagnosis was made, what the findings are, and we really wanted to have better control over those various factors. So we really wanted to do this as a hands-on kind of study. We wanted to know exactly what everybody had. Additionally, we wanted to set that up for a later study where we could then determine whether flexibility changes in the boys over time, and that was something that we would really have to have a before and after picture. But for this particular study, we used a number of different questionnaires in addition to that examination. And we looked at their pubertal status, usually using a scale. We looked at the functional disability inventory, which is a series of generic questions that attempt to assess how a disorder is affecting your life. And it's a tool that's independent of the disorder itself. So it could be pain. It could be another disease state. But what's nice is that it's a very well-validated study, and it's comparable to other studies that have been done in conditions like fibromyalgia and things like that. We also looked at the pediatric quality of life rheumatology module because that actually addresses pain. We looked at the orthostatic grading scale, which is measuring the dizziness with standing aspect. And we also looked at disability due to migraines. What I'll give you here is just a little bit of the results because, in fact, we still have to collect a few more. The male study, the portions of the male late post-pubertal group, it was just too small a number to make meaningful comparisons, so we have to increase our enrollment for the males, and we've actually been doing that over the past number of months, and we're basically about done with it, but that means that where we stopped with our previous analysis doesn't include those numbers. But this first result is a comparison of the functional disability inventories, meaning how much disability was experienced by our patients due to the illness. And what this FDI score, which is this line going up the left side, it ranges from 0 to 50, and it's assumed, or the cutoff point for having mild to no problems is 10 or less. Anything above that is now a moderate problem or moderate disability, and getting up higher is into the severe category. So what we see is that for the boys and the girls pre-pubertal or early puberty, that both of them had average scores of less than 10, not too much. The late post-pubertal boys also had a score of less than 10, but it ranged up a little bit higher. So there was no difference in the boys in the early and late pubertal stages in their functional disability. But again, this number is limited just because we only have 5 of the late post-pubertal boys. In contrast, with the girls, the functional disability inventory score actually increased, and it increased with a significant difference. So it really looked like that post-pubertal phase is when the disability due to the symptoms really begins to escalate. Likewise, we see that the orthostatic symptoms really seem to behave the same way. And this orthostatic grading scale has it's just a 5-question exam, and it ranges up to about a score of 20, I believe is what it is. Now I'm blanking on exactly what the top score is. But usually a score of around 4 or 5 or less really would imply mild or to no symptoms at all. And here again, we see that the boys and girls are below that threshold cutoff, and the late pubertal girls have advanced beyond that point. And these results are actually comparable to some of the other studies coming from other countries on orthostatic symptoms in EDS patients. So even though those studies that were done in those other countries were studying adults, that pattern is really established in the teenage years. So our data is incomplete for the older boys, so we're still doing our data collection. But it demonstrated that there's an increase in disability and dysautonomia in the teenage girls. And when we looked at the age of symptom onset, that was about 11 years old, plus or minus 1 year. and the average age of menarche was 11 years old, plus or minus 1 year. So these really seem to be closely matched, although I have to say these are not fully correlated, meaning that the menarche does not always immediately precede the symptom onset. Sometimes it goes backwards, so sometimes we'll see symptoms start at age 10 and then menarche happens at 11 and a half or something like that. But the general age range and that transition from childhood to adulthood really seems to be the time when things take off. So this really seems to support the hypothesis that the symptoms are increased by female hormones versus male hormones, which seem to be protective. Now, does it prove this hypothesis? The answer is actually no. It does a nice job of supporting it and making this a statement that we need to do more studies. But what we really want to look at now is a more longitudinal study, meaning we want to look at our patients over time and look at those children before they hit puberty and after that they hit puberty and see if boys and girls really proceed in different directions at that time. So what does this allow us to do? It allows us to make a different kind of model. So now we're looking at what I call a threshold model. And the idea here is that everyone's going to be born with some tissue quality, and some of it will be higher, some of it will be lower. And the higher the tissue quality, the more normal the joint mobility is going to be. And we know that there are some patients that are going to have this asymptomatic hypermobility where their tissue quality is less so that there's more instability of the joints, but they don't actually have all the other associated problems. And this may actually be why we see our boys and girls look fairly similar in their younger years, is that they are born with similar connective tissue quality, but then when puberty hits, modifiers begin to act on that tissue quality, and as a tissue quality decreases, that allows the hypermobility symptoms to become manifest. Whereas with some of the boys, their hypermobility may actually decrease to where they actually have now more normal joint mobility. Now, the question here is also what else could actually change the tissue quality. And some thoughts are inflammation. We've seen some of our patients have more, seem to be doing well until they have an inflammatory event such as mononucleosis infection, or we've had some patients with inflammatory arthritis conditions where once that arthritis is under control, then their overall symptoms decrease over time. Could diet and nutritional factors be involved as well? And that's a possibility as well. And so some of our patients are taking different vitamins and things like that. Some of them have tried different diets. At present, nothing has been proven on any of these, but it's certainly an area that could potentially change the tissue quality. So now that what this model looks like is more of a relational model rather than everything thrown into the same bag. So what we're looking at is an idea of having a baseline connective tissue quality and stability, which for females, the increase in female hormones then reduces that tissue quality. This leads in turn to two problems. One is decreased joint stability, and the other is the increase in orthostatic intolerance. Associated with that increase in orthostatic intolerance, I put in there that dysautonomia and norepinephrine imbalance may be a part of this, and that's coming from some other related studies, but was not directly tested in this particular study. And the decreased joint stability and increase in orthostatic intolerance are going to contribute to that functional disability, and then the pain that comes from the joint instability will also contribute to that disability. And that there also may be some interactions between this dysautonomia and pain itself. So now we have a relational model where we can actually look a little bit more at if we make an intervention on the joint stability, does that change the functional disability? It's something that every one of these arrows should allow itself to be tested and potentially have an intervention. So that is a model that describes the results from our study. And it's nice, but it still has a question that says, where does all this stuff actually come from? For example, I talked about orthostatic intolerance back here, but how does connective tissue cause orthostatic intolerance? So we still need a model of pathogenesis. The model that we've developed here, that previous model, was really just a model that says there are going to be certain factors that modify connective tissue that change the likelihood of developing symptoms. If we can intervene on those factors, we might be able to change the development or progression of those symptoms, but it still doesn't tell us where everything comes from in the first place. And as I said, the implications of building this model is that a model of association helps us look for other problems when one problem is identified, but it really has to serve as a framework for this model of pathogenesis, which is something that can be tested systematically, should allow us to guide our treatment choices, and then can be understood by physicians and patients alike, so that it's no longer a collection of problems, but really a series of hierarchies that allow us to follow from the root cause down the different pathways to understand where all the problems come from. So what's interesting is that we already have one model of pathogenesis for Ehlers-Danlos. It's just not talked about a lot because we really focus on a lot of different things, more so on pain and some of the dizziness and heartbeat kind of irregularities. But really, proprioception is quite an interesting model. And in the majority of patients, the sense of proprioception is impaired. And the question of what is proprioception is that it's the spatial awareness. It's knowing where you are in space and how much weight you're carrying. It also has to do with the relationship of your body to other body parts. So is my hand behind me or above me? And if I close my eyes, do I still know exactly where it is? When people do not have good proprioception, they tend to do things like look clumsy as kids. They might have problems running into things, tables, chairs, and door jams. Some of our patients describe difficulty learning to ride a bike. Walking up and down stairs at night when you can't see the stairs has been a problem for some of our patients. And some of our teenagers will even describe that on sports teams they get nicknames like Crash or Chaos because they keep running into other players. So this proprioception is really important for understanding where you are in space. And this has been statistically shown for Ehlers-Danlos. And there was a recent meta-analysis done that was very nice. A meta-analysis is a study which looks at all the other studies out there and tries to pull in data from multiple sources to create a more robust analysis. Usually these studies are done in small patient groups because nobody really has a whole lot of money to put toward this, so they might do 10 to 20 patients. Well, that's nice, but it's not a lot. What you really want to do is have 200 patients in your study or something like that. And so a meta-analysis can compare multiple different studies and aggregate them. And what it showed is that patients with EDS had poor lower limb joint position sense. So if you move the toe up and down, they don't know which direction it went. There was an increased threshold detection to movement, meaning that if a patient was suddenly shifted off balance, they wouldn't necessarily know that they were suddenly moving or shifting to one side or the other. And there was also a difference in the finger positional sense. So again, similar to the toe, if you have a patient close their eyes and then move their finger, patients with EDS are not likely to know which direction it moved initially. Now, eventually our patients tend to get it, but that initial deflection, the initial movement is not registered. And so all of this is suggesting a problem of sensation. Because of this, our patients tend to have more problems with static postural control. So there's more swaying, and our patients require more concentration to stabilize their body when they've been pushed in one direction or another. So this was a situation where this was tested and shown to be true, and it also guides our physical therapy. Knowing that there's a proprioceptive defect means that our therapists need to work on concentrating on the balance and stabilization of the body from the core. So the therapies are often described as being an inside-out therapy. So sometimes our patients will go in because their legs hurt, and then they start doing abdominal exercises and core strengthening. And the reason they're doing that is to really work on the proprioception, because that will influence how the body is reacting. Well, the question is, where does proprioception actually come from? And it's very interesting because proprioception comes from these things called mechanoreceptors. And these are nerve fibers that sense stretch. Mechano meaning mechanical. So as the muscle is stretched and as it contracts, the fibers will recognize that change in length and tension, and they will change the signaling pattern to the brain. So, and the sensory apparatus is a filament-like structure that stretches, contracts, and it changes the firing rate. And by comparing the stretch and tension of these various muscle groups, what the brain is doing is it's interpreting your relative body position. So by comparing your biceps to triceps, for example, it will intuit where your lower arm is actually moving. So this becomes very interesting because you could argue that because these mechanoreceptors really depend on tissue integrity, that these are going to be impaired. So what this really seems to behave as is that these mechanoreceptors are not accurately responding to changes in stretch. And what I have to tell patients is that, in other words, anything that uses the stretch when you have Ehlers-Danlos, it probably doesn't work right. So this is a very interesting model, and I want you to remember this because we'll come back to this later. And the idea here is that the sensory mechanisms that are based on stretching likely do not work very well. Now we're going to switch gears entirely, sort of, and look at dysautonomia. Dysautonomia has to do with the dysfunction of the autonomic nervous system. And the autonomic nervous system controls all of our unconscious functions. So it's things like breathing, heart rate, blood pressure, alertness, digestion, things like that. And there are two halves, roughly. There's a sympathetic side, which is an activation state, and we often characterize that as fight or flight. And then there's a parasympathetic side, and that's a resting and repair state, and we often call that rest and digest. These two halves tend to be exclusive of each other, so that if you're in fight or flight mode, it tends to be at the expense of resting and digesting. Well, dysautonomia is very common in patients with hypermobility. It's the most common symptom that we see is this feeling faint or blacking out with standing. And in a study from 2003, they looked at 27 patients who had joint hypermobility versus controls. Most of them were female, age 32, and about 78% had some degree of orthostatic autonomic dysfunction, so that dizziness with standing, blacking out, those kind of symptoms, compared to 10% of the controls. And so some of the things that we see with this are fainting, also called syncope. We see orthostatic intolerance, just that sensation of fainting when you're standing. And also we can see this postural orthostatic tachycardia, which is often abbreviated as POTS. Now I should mention that POTS is a very specific thing. It means that there's an increase of the heart rate by 30 when you go from laying down to standing, without significant changes in your blood pressure. A lot of our patients have some form of orthostatic symptoms without meeting the formal diagnosis of POTS. But the problem is that that POTS term has become so ingrained in the discussions that a lot of patients will say, I've got POTS, go to the cardiologist, and the cardiologist will say that, well, you don't really have POTS, and then the patients will get mad, despite the fact that the cardiologists still think that there's a form of dysautonomia. So just wanted to state my word of warning. If anyone has those symptoms, don't be married to the word POTS. You can still have some dysautonomia even if you do not meet that formal definition. So there has been more research since that initial study, which came out in 2003, but only one study, really. And it showed some similar results. And what it was doing was repeating some of these studies in patients defined more properly as Ehlers-Danlos hypermobile type instead of the hypermobility syndrome. While most of us kind of believe that EDS and hypermobility syndrome are pretty much the same thing, there are some differences in the definitions that mean that we have to be very careful of how we define these. And a lot of people feel a lot more comfortable if you can accurately say, yes, I indeed labeled everybody correctly as EDS instead of this hypermobility syndrome, which is a state that could actually come from a couple of different problems, including EDS. But at any rate, what this study did is it demonstrated that there was decreased central responsiveness to sudden shifts in the blood pressure. And that's, what we recognize. You stand up and you begin to get faint because your blood pressure doesn't change and send the blood back to your brain. And the important piece here is that it also found that there is increased peripheral sympathetic activation. So what you're looking at is the cardiovascular system is unresponsive, but the peripheral, the rest of the body, really seems to be activated. And this is important because it really relates to some of our other symptoms. We know that patients who have POTS and dysautonomia have poor sleep efficiency. And there is some anecdotal evidence out there that sympathetic activation occurs during sleep. And if this is occurring during sleep, it's probably waking you up or bringing you to higher levels of sleep, more superficial levels of sleep, which mean that you are impairing your sleep restoration pattern. Also, we see that there are symptoms of racing heartbeat related to POTS, and these might be interpreted as anxiety or panic. And although orthostatic changes can often bring out these symptoms, so when you stand up, some of our patients get that racing heartbeat, others don't. But we also see some of our patients just have racing heartbeat when somebody walks into the room too fast and bangs the door as they walk in. So this anxiety and panic and poor sleep efficiency really seem to have some bearing on the relationship to dysautonomia. And this poor sleep and anxiety may actually feed off of each other, so that if you're not sleeping well, there seems to be a increased activation the next day so that you're more anxious as a result. So the increase in peripheral sympathetic activation, talking so long I can't say anything anymore, it would be a good explanation for the racing heartbeat, anxiety, and panic, and sleep dysfunction. And this would be a very important piece to allow us for intervention. And as said here, we've seen this talk before because I've actually gave this talk at the most recent EDMF meeting. And there was another talk that was actually preceded mine that talked about some of these aspects as well. We're doing it a little backwards on the webinar series because Alan Pasinki is going to be talking about this at the next session. So cross that out and just say we'll see this next. So where do all these sympathetic effects come from? And the hypothesis here is that there may be aberrant baroreceptor functions causing a dysregulation of norepinephrine release. What? Okay, let me go back. Baroreceptors are receptors that are just like those stretch receptors in the muscle, just like they are mechanoreceptors, but instead of stretching linearly, they stretch circularly. They wrap around the aorta, they wrap around the GI tract, and when they stretch out, what they are sensing is pressure. So if your baroreceptors, those little stretch receptors in the aorta, are not working, then your body really does not know what your blood pressure is. And in fact, that's a very important piece because your body needs to know what your blood pressure is, because with every heartbeat, your brain is trying to regulate the rest of your blood pressure and distribution throughout your body. And with every heartbeat, there is a reflex that goes to the heart to release norepinephrine into the system. And what that norepinephrine is supposed to do is go out to the peripheral blood vessels and clamp them down. That provides a peripheral resistance to maintain your central blood pressure. But what we know is that patients who have POTS have poor baroreceptor responsiveness. And one of the things that we know about baroreceptor function is that it's directly related to arterial compliance, meaning how well that vessel wall moves. And so what we would expect is that with the dysautonomia and POTS, the baroreceptor responsiveness is decreased. And this is likely going to be because that recoil and the stretching and recoil function of the aorta is just not working very well. Now, is this true? I cannot prove that to you at this point. This has not been demonstrated, and that's because there are lots of technical problems involved with it. But what it means is that we really have to evaluate this a lot more carefully. But what this allows us to do is to really look at this model and alter it and tweak it and build it into something that may be a better system for testing and evaluation. So here's the old model. The old model says if you have weak connective tissue, it might lead to a joint dislocation, and then you'll have pain. That was the simplistic thinking that was going on during my residency. Not too long ago, but I guess the years are getting on. Now, we had a few modifications. I've heard, maybe soft tissue herniations can give some pain from time to time, too. Not a big deal. That was the revised old model. This is our current model that we employ in the with our pain clinic and with our physical therapy group. And the idea here is that the weak connective tissue impairs the sense of proprioception. The proprioception impairs posture and balance, and those are direct contributors to problems with pain. Additionally, the weak connective tissue can lead to joint dislocations, and the likelihood of having a joint dislocation is higher if you have poor posture and poor balance, because you're more likely to step off the curb without knowing exactly where it was, twist your ankle and pop something out of place, or even have a small fracture on your ankle. Things like that. What we tend to see with fractures in this condition is that I call them goofy fractures. They have the same kind of forces that normal fractures would do. They just happen under weird circumstances. Now, what we also work on here is the coping skills, because coping skills help modulate how you behave when pain is happening. And a lot of our patients become very withdrawn. Their world gets a lot smaller. They don't want to go out and do the things that they used to do because it hurts too much. And that creates a cycle of inactivity and poor mood, and those just really circle back on each other until you get a child who's really not leaving the bed much at all. What I did not include in this are the problems with the GI system or the problems of dysautonomia. So this is the current model, but I still think it's incomplete. So what I'm looking toward is building the future model, which is looking at how the connective tissue may impact these multiple different systems. So here in the boxes which are dark blue, I'm looking at what I would consider the most root causes of all of the problems. So we know that the connective tissue is going to have a direct bearing on proprioception, but it may also have changes in the way the baroreceptors of the blood vessels and gastrointestinal system work as well. We already talked about the proprioception as it relates to posture and balance, so we'll talk about the baroreceptors. The blood vessel baroreceptors lead directly to dehydration. If the baroreceptors don't tell you that your blood volume is low, it's kind of like having a car that has no gas gauge, or the gas gauge is broken. And if you've ever driven a car like that, you know that you're always running out of gas because you never quite know exactly how much gas is left in the tank. The little light that tells you to go fill up never comes on. Well, if these baroreceptors are not working adequately, then what we would tend to see is that our patients are not going to have the compensatory mechanisms that go along with low fluid volume. The compensatory mechanisms are going to be thirst, getting thirsty, craving salt, and also the kidneys will hold on to salt and water as well. When those things don't happen, we get a child who is not thirsty and tends to pee out everything that they take in. So our patients have higher fluid requirements than all the other patients out there. So when it comes to adults, what we're typically talking about is that you have to have about a half gallon of fluid per day. That's just a general recommendation for everybody. For our patients who are having problems with dizziness with standing, what we have to shoot for is more like 3/4 to nearly a full gallon of fluid to offset those symptoms. But not only that, the dehydration not only contributes to the orthostatic changes, but the baroreceptor response is going to change the way your body is processing the norepinephrine. And what seems to happen is that if it's not being released into the circulatory system to change your blood pressure, then your body really seems to act like it's missing that norepinephrine. And so what happens is when in situations like that is that the receptor systems often become upregulated when there's a deficiency of a neurotransmitter. What will happen then is when norepinephrine does get released for other purposes, meaning it gets released not only for immediate blood pressure management, but it also gets released under situations of stress, of panic, things like that. Well, when that norepinephrine finally does get released, it meets with an upregulated receptor system, and the result is a large response. So this baroreceptor may play directly into the sympathetic activation that we see. That sympathetic activation would then in turn cause sleep impairment, which will have will contribute to chronic fatigue. That sympathetic activation may also lead to anxiety and panic. And that sleep and panic, those aspects are really intertwined. And they work on this whole system. I kind of think as a tumbling system. The three factors just seem to play off of each other and magnify. Meanwhile, our coping skills, as we're trying to decide, how to feel calmer when you're in pain and trying to use those specific techniques, are going to meet with a lot more resistance in a patient who's feeling anxious and panicky and feeling like something is really, 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 really wrong, when in fact it really may be an activation of that sympathetic nervous system. So these factors are going to play into that pain and to the headache and the abdominal pain. And I think this is a model that is still incomplete because we haven't gotten into some of the issues about are we looking at issues of GI permeability and those other things that are kind of ideas that are floating around out there. But what this model allows us to do is begin to look at these various factors and test each one more systematically. And then in some of them, we can actually really begin to make more interventional-based plans. So I've come to the end of this. I would like to thank all the people that have been involved in the study that I presented to you. And Caitlin Harity is the genetics counseling student who was really helped put all this together. Jody Johnson and Kristen Shipley are the genetic counselors that helped implement this. Betty Shorey is the other physician who sees the Ehlers-Danlos patients. And then we had Tracy Ting from rheumatology who has done similar studies and helps us out a lot with the formatting. Sue Shang helps us with the statistics, and Sarah Bucher was instrumental in helping keep us organized with our internal review committees. And at this time, I think it's time to go to questions.
Well, it's a great presentation and very detailed, new information that we hadn't seen before. It's always interesting to see what's being done in the way of research, and we really appreciate that. So, yes, you should be able to click on the Q&A box and read those questions and answer them. It'd be great. Thank you.
Okay, so the first one was, I'm sure there are many others like me diagnosed with EDS. The regular doc has heard of it, but you don't have anybody guiding the kind of treatment. Went to Vanderbilt for the autonomic dysfunction. They did the tilt test and another test, but they rushed her out at only 5 minutes. And let's see. And so I'm left in limbo. Also, no support groups in Tennessee. Well, I guess the last question first. I think Dr. John, maybe they can help set up a support group in Tennessee. As far as what to do about this, there are a few generic things that kind of go along with the dysautonomia that goes along with it. And the first part is that everybody needs to make sure that they're getting enough fluid and enough salt. And I kind of talked about, if you're not getting at least a half gallon, you need to start with that and then increase it. A lot of times, a lot of the symptoms can improve with that. There are other modifications that are fairly simple. For example, we found that some of our patients are really doing quite well if they just get some shorts that are compression shorts. I won't go into brand names and all that kind of stuff, but that seems to increase the vascular resistance of the lower extremities, and that helps keep the blood pressure higher up in the body, so it's not likely to go down to your toes as much. There are other medications that can be used as well, and then these really have to be picked specifically. So we see beta blockers are commonly used. The idea with that is that they can decrease some of the sympathetic activation that comes about with this, and they can decrease the amount of racing heartbeat that you might get. They do not change the fluid status, though. So you still got to get a lot of fluid into you. Otherwise, you might find out that your system is actually being held together with norepinephrine, and when you take it away with a beta blocker, then it really bottoms out. So you really have to kind of approach it from two different directions. There are a couple different medications that are used to kind of help improve the fluid balance, one of which is a hormone called aldosterone, or Florinef, sorry, and that one helps resorb water and salt from the kidneys. And then there's another one called midodrine, which causes peripheral vasoconstriction, so it causes more of the blood to be held centrally. Those are things that are not terribly unusual. In fact, most doctors should be fairly comfortable with beta blockers and don't necessarily require specialized people to be taking care of it. They do require monitoring, though, so you can't just go on those and go on your way. So you do have to have a relationship with somebody who can manage those. The next thing, let's see, does EDS ever mimic celiac disease? So I guess that's difficult. Just trying to decide how to answer that. So celiac disease can cause a lot of GI problems, a lot of GI pain. We often see more diarrheal kind of episodes when exposed to gluten. We've had lots of patients go on certain kinds of diets, and some of them will go gluten-free, and they'll tell you that they feel better. And then some of them will kind of say, and then I kind of went off of it, and I'm still doing okay. So, there is some overlap because basically a lot of the symptoms that come from the GI tract are kind of generic and difficult to specify one problem versus another. So yes, it can mimic, but we've had some of our patients actually seem to do a little better when they're actually kind of actively working on that. The next question is, I'm having trouble finding a practitioner to help me. I went to see a rheumatologist who tried to diagnose me with Marfan's, and it says I'm only 5'9". Any recommendations? Well, the biggest problem with that is location to some degree. There are providers throughout the country, but they're kind of scattered. And, I think one of the problems that we're still kind of facing is that the perception of this still is that you have to go have a specialist who is the expert in this in Ehlers-Danlos. And it can be helpful just in that it removes some of the roadblocks. But, for many of our patients, the resources that are available, like specialized physical therapy and things like that, may not be available in a given area. And you still have to have a regular doctor who can take care of the regular aches and pains that come in through the course of normal life. So the best advice I can give, if you cannot find anybody in the immediate area, is to find somebody who listens and would be willing to talk to other people. Because if you've got somebody like that, then you can actually develop a longer-term relationship where they might be able to actually work more effectively with you. That's the hardest thing to find because, the pressures are out there now that you're only supposed to be spending about 10 minutes with your patient. And I think the biggest advantage that we have in genetics is that the expectation is still that we get 45 minutes to spend with our patients, at which time I can do a lot of talking like I've done. So that would be the first part. Now, as far as specialists, there are some resources out there, and the EDNF, Ehlers-Danlos National Foundation, I do believe, has some list of providers out there. I guess the question always comes up of how well they're maintaining that list for a given area. So how can you tell if abdominal bloating and distension is due to gastrointestinal dysfunction or dysautonomia, splanchnic hyperemia, or blood pooling? Well, the answer can be difficult. Those systems really play off of each other, or as I said, they kind of, one system has can actually sabotage the other. So sometimes you see some of our patients will eat, and because of their digestive tract pulling blood toward it, it pulls blood away from the central circulation, and then they begin to feel dizzy and faint and nauseous. So now you've got a person who doesn't like to eat because they feel awful every time. So these are, interrelated problems. And sometimes that question is not well answered. We do see things like poor gastric motility, and there are some therapies that are effective for that. But yeah, I mean, the biggest problem is how do you tell the difference between one versus the other? Sometimes it's just a matter of trial and error with the medications to see if you decrease this dysautonomic response. Do you see changes in your symptoms? Let's see. The next question is, how can I find research studies on EDS near me to volunteer for? So the general places that studies get listed, let's see. The first is NIH has a website that will list ongoing clinical trials. Typically, those are trials that are medication-based. So they may not be the same things that, as what we have done, which were more questionnaires and things like that. I'm trying to remember off the top of my head. I can't actually remember what that site is called. Then there have been some other EDS support groups that have been listing various studies. But the biggest problem that I would say is that there are not a whole lot of research studies on EDS. That is the biggest deficit that we face. The next question is, will you be looking at women in perimenopause and menopause? And that's when I begin to present with the most disabling symptoms that led to my diagnosis. And the answer is not just yet. What we're trying to do is really paint in broad strokes, I guess would be the way to describe it. We're trying to identify those areas where we think that we're going to be able to make the biggest statements to start to flesh out a model of how we think this is working. And then as we turn toward demonstrating that model in different ways, that's when we'd be looking at other stages in life, which could include pregnancy and menopause. But in the short term, I have no immediate plans, but that's sort of on the radar for down the line. Will there be a way to print the slides of this presentation? I don't know, but I know that these are pretty much the same slides that I used at the EDNF, and I do believe that they will be posting them.
Yes, we will post the slides in a PDF format on our site, and you should be able to print those.
Okay, and then the next is my daughter, age 8, was diagnosed with EDS and had a rapid heartbeat episode where she became pale in kindergarten and had to sit down, and it resolved quite quickly. Could that be POTS? And it was a one-time incident, and it led to a finding of bicuspid aortic valve and later EDS. So again, POTS has become a very popular shorthand for describing the symptoms of dysautonomia. I wouldn't necessarily call it POTS, and it's also kind of difficult to say a whole lot about it if that's the only episode that there's ever been. For most of the kids who are undergoing that kind of problem, what we'd really kind of push at this point is really just the fluids and then see how it goes. A lot of the kids, this is the kind of thing that can happen from time to time in other children as well, so it's always a little difficult to read into it too much at this point. I think the real question of whether something more is going on will be whether it is tending to recur. The next question is, how can a patient best raise interest and awareness in EDS outside of your presentation? The goal is to ask them to the upcoming EDNF physician training day. I guess that's it's a good question. I think that's a question I think actually would probably go better toward John, because I think it really relates to how do people relate to media on the internet. And I can tell you, I'm not an expert on that. John, do you want to speak up on that?
Sure, I can make some comments. One of our goals is to create support groups, and then we will give you some suggestions and some advice about how to go out and do awareness activities. And, for example, the Anna could comment that she's gone to the Cleveland Clinic and set up a table in the cafeteria and passed out literature to doctors and patients. She's gone to schools during a service fair and passed out information to children that have to have volunteer hours. And hopefully they take that home, and it's related to EDS. We've gone to churches, we've gone on walks, and there's a variety of presentations that have been given in local communities. We actually have a mini presentation if you're wanting to give a presentation to an adult education class. So contact me, Anne-Marie, and I'd be happy to tell you more about some of the awareness activities that we are doing in the local communities. So thank you for that question.
If somebody has a support group in their area, a great way to raise physician awareness is to offer, information cards about the support group, or just some flyers that talk about EDS would be helpful too. So yes, please contact us and we can help you with those ideas.
So the next question is, what is your take on young EDSers and competitive sports? I typically have only one hard and fast rule, which is for boys, no football. And that just really relates to the number of patients I've seen who've come in at the age of 25 to 30 who are now on shoulder surgery number 5. And you say, what happened to your shoulder? Oh, it got knocked out while I was playing football. What we really want for our kids is for them to be active. And that is for a couple of different reasons. One is we want good, it'll help with their muscle tone, which can help contribute to joint stability, although we kind of need to modulate that and make sure that they're getting good physical therapy at the same time. The other reason is that, I didn't get into this, but one of the ways of changing the baroreceptor's responsiveness is through aerobic exercise. And aerobic exercise, probably the way it works, if these models are correct, would be that it's a way of releasing norepinephrine into the system. And so basically you're giving your body a dose of what it's been looking for. So what we really want is for people to be active and exercising, and we want to encourage that as a lifelong pattern. What we really have to do, though, is to try and find the things that help support aerobic activity without blowing out joints. So we do have to make good choices, and there's no good, rule of thumb of what should a child actually do, because I've seen some boys who are quite active in multiple different sports and having zero problems, and you really wouldn't want to tell that kid, you are not allowed to play any of those sports anymore, although I do tell them they can't play football. With the girls, the problematic sports I tend to see are more gymnastics, cheerleading, and ballet, just because they put a lot of stress on the joints. So with those ones, we kind of say you just have to give the warning that some of the lower levels where they're just kind of doing it as having fun and learning some balance and things like that are probably okay. But if you're getting to the point where it's becoming a competition for them, where they are looking at, my life as a ballerina, we may need to have some more realistic expectations about that. But for most of the younger kids, the competitive sports are not such a big deal because the speeds are lower, the crashes are lower impact, things like that. When they get older, then we have to be a little bit more worried about, how much contact are they actually going to take. The next question is, says, while I agree with the increase in hydration, I tend to disagree with the doctors when they say to increase the salt intake to 5,000 milligrams of sodium or more. Should the sodium be increased, and if so, why so much? So at least I can feel confident that, the people that are recommending this are cardiologists. And, because the cardiologists are the ones that are normally telling people don't take any more salt, don't add salt to your diet, things like that. So the way I think about the sodium balance is that the rule of water in the body is that water goes where the salt is. And so one of the dehydration response mechanisms is to resorb salt by the kidney mechanism. It will pull it back into the body. But if that system is not working, then everything just keeps dumping through. So what we'd expect is that a patient is more likely to dump fluid and salt. And as a result, that loss of sodium means that you're not able to hold salt, to hold water in the body as well. And so some of the the medications work by helping reabsorb sodium at the level of the kidney as well. So I think that's the idea of where the sodium increase is coming from. If you think about it, the kidneys are kind of like a sink, or they're the drain that goes away from a sink. And what you're trying to do is fill the sink up, but you're still leaving the drain wide open. And so if you want to fill that sink up with a wide open drain, you have to turn that water on a lot harder. And that's kind of what you have to do with the water and the salt. You have to increase the both of them in order to maintain the blood pressure. The next one says, Dr. Neilson, you've articulated the barriers that many of us have in getting good health care. The obvious question is, how do we talk to our health care providers, especially new doctors who don't have knowledge of the conditions? And to most doctors, EDS means that I'm more prone to arthritis, or that I am prone to aortic dissection. Let's see, they're ignorant of the nuances of the myriad ways it can present. And how do we educate our doctors? We need a cheat sheet. Yeah, I agree. And why do you think there are a few excellent centers devoted to connective tissue disorders, but they are few and far between, including New York, and they are lacking in many large metropolitan centers, including New York? And is there anything being done to get EDS into the medical school curriculum and into the training programs? So the last part is I can't actually answer whether that's being done on any kind of global scale. I think we're still at the level of people don't even recognize, it's not really on the radar of most people that this is a real problem. And as I said, some of the barriers are it's not taught and it's not well understood, and people just haven't been exposed to that. So, we're really trying to work with when people are rotating on genetics to really get them through the connective tissue clinic, especially if there are any of the kinds of residents who are actually going into med peds and things like that. We're trying to break in a little bit more with UC and develop more adult-based clinics where we might be able to actually have more resident training of internal medicine, because I think, the problem with genetics is that it's been largely based in pediatric programs over the years, and that means that most internal medicine docs don't know much about genetic conditions at all. And yes, I think we do need a cheat sheet. We give cheat sheets to our patients as they come through. But, I was talking to John that we probably need to have a few kind of basic, my talk is more about some of the stuff that we're doing and some of the models we're trying to develop, but there needs to be a few resources that just say more basic things. And, the EDNF has some of these as well, but they need to be updated. What doctors are recommended to help treat EDS? It really kind of depends on what's going on. And what I would love to say is that what you need is to have a nice, good listener for your internal medicine doc or your primary care provider who can help, work through which of the problems actually need further evaluation and not. But we commonly see some of our patients go to pain management specialists, cardiologists, GI specialists, neurologists, often in the context of headache or other kinds of things. Orthopedics and neurosurgeons are sometimes needed as well. And I should mention myself as a geneticist, but honestly, the care needs to be more spread out among the medical field, just because there's just not enough of us geneticists that do this to take care of the vast numbers that we expect are out there. The next question is, why haven't more genes been identified for EDS hypermobility type? This is a great question. The problem is that we have one gene which accounts for maybe 2.5 to 5% of the entire population of EDS hypermobile type. So 95% of our patients have no identifiable genetic change. And there are a couple of reasons that could play into that. First of all is that there may actually be, so first of all, we would recognize that there's going to be a number of different genes involved. But the second part is that this is more common than we really expected it to be. And, for example, we are now doing at our institution some of these studies called exomes, where we sequence every single gene that we know about at the same time. And when we look for the variants, because typically what you get from that evaluation is 25,000 different things that you have to then go through and decide which one of those is important. So one of the first steps that you do is you eliminate any gene that has a population frequency of less than 1%. Well, if the population frequency of Ehlers-Danlos is 1%, you've just eliminated all the genes that could have been. So that's one of the areas that it fails, is that our techniques that have traditionally been used to find genes have depended on good family structures where we know that there's only one gene segregating through the family, and that the gene is rare enough that we're not going to find it in a unscreened control population. Well, if we say that 10% of the population has some degree of hypermobility, and that's the current estimate, then this is too common, and that assumption of rarity fails. And even worse is that we sometimes see families where mom has hypermobility and dad has hypermobility, and what could happen is that a child could get one form of hypermobility from mom, the next child could get a form of hypermobility from dad, the next child could get hypermobility from both, and when you get into that situation, everything's just too much of a mess. That mapping strategy will simply fail. So, and if you can imagine, you think about other disorders like diabetes, hypertension, and things like this that are fairly common in the population, it has been really hard to find genes for those different conditions. And I think we probably have a better chance for Ehlers-Danlos, but because it's on that population frequency, it's going to fail on that level for that reason.
Yeah, let's see. Is it acceptable to only have a clinical diagnosis of classic EDS, or are there situations when genetic testing is most helpful? Testing is expensive, so why would it be necessary? Yeah, I can tell you the number of times. So, we see about 900 patients per year, and the times I do genetic testing, I probably do it between 5 and 10 times per year. And so it's not very often. And usually it's because I'm looking for something a little bit more specific, and I usually have reasons where I'm trying to say, you know what, we need to do something a little bit different for you, because I think there might be something a little bit different going on. But for classic and for hypermobile, even though testing is available for classic, I don't always do it because there's not really much, it doesn't really change very much. And, this idea that you have to have a genetic test in order to have a genetic diagnosis is something that's really only popped up in the last 5 years or so. Before the Genome Project, where we identified all the genes, we really didn't have many genetic tests at all. And so almost all of our genetic diagnoses were based on taking a look at you and just deciding what you had based on your physical findings and your natural history. And there's no reason to throw that system out. But because of all the advanced testing that is available, people think that now it's absolutely necessary. And it is not always. Let's see. My daughter has episodes of her heart racing and rapid breathing. We call it anxiety or a panic attack and are treating it with counseling. If it is a physical problem rather than psychological, how should we treat it, and which doctor or department should treat it? Through our institution, we often have our patients evaluated through a specific clinic in cardiology, but that's not always available at every kind of institution. So let's see, counseling can help because counseling can give some of the techniques that may allow a person to exert more control over the situation. to be able to have some self-awareness to say, okay, something is not about to attack. It's really just this physiologic response. And sometimes that can have a calming effect that can help settle the system down. So the counseling is still a useful piece. And in fact, for most of our patients, we still try and get them to go to counseling, even if we're doing medical therapies. The medications that are used are, I've described a little bit earlier, things like beta blockers and things like that can sometimes be used. And some of the psychologists or psychiatrists, rather, have actually used those before. So, in talking with some of our colleagues, they're not always they are not averse to using those. Let's see. My daughter is talented, a talented artist, but struggles to draw and paint because of shoulder pain. And I've heard of surgery on the tendons, but I'm scared. And have you heard of this? So for surgery for the tendons, it really, or for shoulder surgery, it really kind of depends on what your goal is and what's happened in the past. And first, I should say that before you ever do surgery, every other pathway really needs to be exhausted or attempted and exhausted before you really get to that decision. So physical therapy is usually the first thing that you go for because if it's a simple matter of you're holding your body wrong and that's allowing this muscle to spasm, and if you just relax that, it will all fall into place, that may be the answer right there. But if it's actually something more, what I'm more comfortable with are surgeries that are looking to remove pieces of inflamed tissue. Some of our patients have had damage to the shoulder and joint capsule tear and things like that. And sometimes that can set up a little inflammatory nidus that just continues to cause problems. So sometimes shoulders need to be cleaned up. Surgeries that are designed to just tighten things up, I worry about a little bit because tendons can stretch out again over time. Now, we do have some surgeons that are more aware of this issue, and they will use different techniques, so they won't necessarily sew tissue to tissue, which you might expect would tear and rip through. But they may use different techniques that are more like, they seem analogous to putting a wall anchor into drywall, but what they're doing is anchoring it to the bone, things like that. So there's a lot of different variables involved in that. Okay, let's see. So I've seen several patients with EDS and find significant weakness. I have read some research regarding the links between muscle force generation and should it be added to the future model? And hello, Sheila. So I think yes. I mean, there are a number of ways that could be involved. One could be that the stretch of the muscle might allow those sarcomeres to overstretch so that they're no longer overlapping effectively, and that could be a bit of a problem. There are specific types of Ehlers-Danlos. So for the tenacin, if you are missing 2 copies of that particular gene, it actually creates a muscle myopathy. So I do believe that's an issue as well. And, we've seen variations where some patients have very good musculature and just loose joint capsules and things like that. And then we see the other end of the spectrum where some of our patients really have true weakness and low tone and things like that. And they seem to have more problems really getting the body under control. So that does play into it as well. Let's see. After passing out many times, I've learned to do deep breathing exercises to control my blood pressure. That is great. Actually, they call that some of that counter maneuvers. During the tilt test, I kept reminding myself to let the normal symptoms happen, but I found myself changing my breathing to accommodate, and I threw the test. I was told the symptoms weren't severe enough to be called POTS. Well, this is my disclaimer. It doesn't have to be POTS in order to be dysautonomia. And are there other ways to find out if you have POTS, OT, or some other type of dysautonomia? Well, in many cases, our cardiology colleagues may actually make a diagnosis of cardiogenic syncope or something similar to that, and it may be based more on the symptom complexes rather than the tilt table test. So that is a useful test, but you don't necessarily have to pin your entire diagnosis on the results of that. We can still kind of put it into clinical context, and sometimes there are some medications that are still safe enough that you can try medications to see if it changes the frequency of those symptoms. Have you ever used a smart pill to test for gastric motility? And if you have a prep similar to one for a colonoscopy, would that invalidate the smart pill results? The second part, I have no idea. I don't know if a colonic prep would change smart pill results. I have never actually used a smart pill to test for that. We do have one of our specialists in GI in the pediatric arena here who has been working with that through a specific research grant that he has, and he is looking to expand that in the future. So I'm hoping that we'll be able to look at that a little bit more. But currently the answer is no, I don't have any direct experience. Are there any types of brochures available for physicians? And how can we help spread awareness? So I think we kind of addressed some of that before. Can dysautonomia include GI manifestations like recurrent vomiting? The answer is yes, but there's a lot more that goes with the recurrent vomiting too, so I wouldn't necessarily pin everything on that. Definitely would want you to see or have that you or the patient see a GI specialist. My 13-year-old has EDS and POTS. Do you think hormone therapy could help getting him through puberty and his symptoms? I probably wouldn't do that for a boy at this stage unless there had been demonstrated low testosterone levels for the pubertal phase. The idea is that as that kicks in, a lot of that stuff tends to resolve. But if you give exogenous steroids to a boy, what you will do is you will shut down the testosterone production by the testes. And so what you will actually be doing in that is impairing their development. And that's a bit of a problem because the testes really depend on a high concentration of testosterone inside the testes to properly produce all the cells that will go on to make sperm and all that kind of stuff. So exogenous testosterone in a young boy, you do have to have some concerns about fertility impairment when you do that. So I wouldn't mess with that unless he just really wasn't producing testosterone, in which case I would really want an endocrinologist to work that up. My 18-year-old daughter was just diagnosed, and it was found on the college athletic exam for dance team. Are there any risks that she should avoid or be cautious in? This is one of those things where you kind of have to evaluate that person by person. Some people are hypermobile and can do all those things and don't have much of a problem. Some people are experiencing lots of joint pain, and in that case, you would really want to evaluate what kind of moves that she's doing and determine is what she's doing in dance team, are those actually bringing about pain for her, because then you may actually want to restrict those activities. For adults, what do you suggest for activity? I was diagnosed yesterday. I have a complex regional pain syndrome with a spinal cord stimulator triggered by ankle foot fracture and torn ligaments. Can't do high-impact exercise. My main form of exercise was yoga, and my doctor told me no yoga for EDS. You can do yoga. You do have to be careful about it. There are certain exercises that you may not tolerate as well for yoga, but if you were able to do it before and weren't having additional pain from that, you could go back to that. Some of our patients like to do other kind of balance-based exercises like Tai Chi. Those are nice for core, for strengthening and stability. Some patients also find that Pilates works for them. as far as aerobic activities, that what I would really be looking for are things that you can do without putting stress on the joints. The best thing that I would consider would be anything you can do in a pool. I'm not sure the status of this stimulator, but that's typically where I see patients tend to do better. The reasons are that the pool actually takes the stress off the joints, and so you can do, most patients can do more and spend more time in a pool than they can out on land. The second reason I like the pool is that for those that have more issues with dysautonomia and have low blood pressure, the water weight will actually squeeze the periphery and provide more resistance. So you actually, it helps support your blood pressure. So some of our patients don't get that heart racing out of control sensation when they're doing things in the pool. And then everything that you do in a pool is a resistance maneuver. So even if you just walk through a pool, you're actually facing more resistance from the water than you would be walking down the street at home. So all those things tell me that this is a very helpful environment in which to do exercise for many of our patients. Now, not every patient can tolerate that, so it's one of those you really have to kind of decide what works for you. And for some of our patients, ellipticals, recumbent bikes, I've even seen some versions of recumbent stair climbers with the handlebars as well, so that you work your hands while sitting down. All of those could work, but the most important thing is finding something that works for you. Is EDS found equally in all ethnicities? It is unclear. We think that it may be, but it's really been biased toward Caucasians at present, and I think that may just be more of what we see as a referral or ascertainment bias. I've certainly seen patients of every ethnicity with it, but I just don't know how frequent it is. Are you familiar with the Curves for Women workout program? I'm afraid I am not, so I cannot recommend for or against it. My sister and her now adult children have been diagnosed with Marfan, and I have been diagnosed with EDS. Is it possible that we have different connective tissue disorders, or is one of us misdiagnosed? And does it matter? So with the Marfan syndrome, that is based on a very specific set of criteria. A lot of the criteria focus on the aorta and aortic enlargement. And so if the diagnosis was based on that, then that's a very important piece. There is genetic testing, and I would, if there was a question of the diagnosis or misdiagnosis, that would be a good situation in which to follow up on genetic testing of the family and extend it out to other families family members who may be at risk. The reason to diagnose Marfan syndrome is that there is a very high risk of going on to have an aortic dissection. In contrast with Ehlers-Danlos hypermobile type, that risk is not very high at all, to the point that the initial studies on aortic dilation came from this institution. The follow-up studies and those initial studies suggested that there was a higher rate of aortic dilation than the follow-up studies said. Actually, it looks like there might be just a mild dilation that seems to go away over time. But the problem is everyone kind of listens to the first paper and then they forget about the second. So for the most part, we don't even do echoes on most of our patients unless there are more suggestions that Marfan syndrome might actually be the diagnosis instead. And there can be overlap in some of the findings, so it is something that kind of has to be worked through with a person that can appropriately evaluate those. Let's see. If you haven't already answered this question, are you encouraging other hospitals to replicate your study? We certainly will. We haven't done it necessarily to date. How can patients deal with uninformed physicians who believe EDS doesn't exist without genetic testing? Unfortunately, that's something that probably patients can't really deal with. It really has to come. When you're dealing with that kind of situation, you usually have to have education of a physician by other physicians in order for them to believe it. It's more of a mindset issue rather than anything the patient is doing. So we have to really just get our information out there in a much more accessible way to physicians, and really get in forms that can be peer reviewed. So that means I think we need to have more and better papers written that are accessible to our doctors. Do you have an opinion on prolotherapy and PRP? It greatly helped my daughter's pain and shoulder function and healed a bicep tear. However, it is expensive, controversial, and not covered insurance. Well, that's kind of my opinion of it, too. And what I've seen with the prolotherapy is I've seen some people go and do that, and it works for a while, and then it kind of begins to not work, and then they go and do it again. And depending on how it gets done, it may or may not work the next time. And so, yeah, I can't necessarily say don't do it because I have seen people kind of feel better with it, but at the same time, it seems inconsistent, and so I'm not fully on board with it. I would really want to see what are the differences. It seemed that some of the differences had to do with whether the platelet-rich plasma was used rather than saline. Can you move to Philly? Well, I do have a very good friend there, but I think my wife would kill me. Other than the drugs mentioned, do stimulants help patients with POTS or orthostatic intolerance? You know, there's actually a bigger list of medications that help the orthostatic intolerance. I kind of gave you the first few that are sort of more commonly used. But we have, there are a few lists out there that include medications like methylphenidate, you know, which is one of the ADHD medications. And that may have a couple of different effects in different parts of the brain, and it may also have some effects on increasing the vascular resistance. So there's more to this than what I've described, but so yes. Have you found any correlation between autoimmune disorders and EDS? I think, let's see, there are a couple of ways of answering that. One is, are we more likely to find that people are mounting immune responses to various parts of their body? For example, are we more likely to see Hashimoto's thyroiditis? Are we more likely to see diabetes? Are we more likely to see Addison's or Graves or these other kind of autoimmune disorders? Or are we more likely to see the rheumatoid autoimmune problems such as lupus, rheumatoid arthritis, things like that? Well, for the first case with the autoimmune endocrinopathy disorders, I don't think that we've seen enough of those to be able to say, yes, that's a real clear pattern. For the rheumatology-based autoimmune disorders, we often see our patients get evaluated in both settings. So they often are referred because of the joint pain to a rheumatologist, and often they undergo that series of testing, and their ANAs will often come back positive on the first time around, and then they might be negative the next time around. They'll do the follow-up testing, and it all comes back negative. So, what we see is that we get a lot of patients that seem to act like rheumatologic autoimmune disorders, but they never actually fully get into that full criteria. And the problem is that a lot of the things that go along with autonomic dysfunction and pain can actually look like a rheumatology disorder. So weird rashes, Raynaud phenomenon, those can actually be sequelae or dysautonomic effects. But everyone says, oh my gosh, that's got to be rheumatology. Now on the flip side, I have seen rheumatologic autoimmune disorders modify the way Ehlers-Danlos hypermobility is behaving. And so those disorders create a lot of inflammatory factors, and those inflammatory factors can be destructive to connective tissue. And so what that seems to do is change that balance. So, if we go back to that threshold model where you've kind of got a baseline and then something tips it over, those autoimmune inflammatory disorders may actually be one of those driving factors. But any direct correlation, we haven't really seen it. And how do you feel about dry needling? And members of my support group have seen great results in this improving muscle function. My guess is that dry needling works perhaps similar to the use of prolotherapy with the platelet-rich plasma. It probably causes bleeding, and the bleeding is probably allowing the platelets to actually get activated, because what we see for a lot of patients is that the connective tissue doesn't do a real good job of activating those platelets. So maybe the needling actually creates a direct trauma that may do a little bit more. And those platelets may actually have a role in improving some of the connective tissue function or repairing various tissues. But it's one of those situations where you hear a lot of people doing things, but you don't see any studies that say if you take 50 people and do dry needling and 50 people and you do acupressure, you know, no needles or something like that, what is the difference? Is there a functional difference between the two? And those kind of studies are not out there. So, and that's what you'd really like to see to be able to support that kind of, or to give your support to that kind of activity. You know, because the idea with research in medicine is that when you talk to a patient, what you want to be able to tell them is what is the relative risk and benefit of doing this, and what's the likely success rate. And if you don't have those things, there's most physicians really don't feel comfortable giving a recommendation because anything else, you know, we get lots of different positive results that other people say that just doesn't work at all. And so it feels very difficult to go out on a limb and say, yeah, you should do that, because if it's got if it's high cost, for example, and doesn't get covered by insurance, you feel very conflicted about telling somebody to go out and go do that unless you really know it's going to work. That's, I think, the problems that we run into. Let's see. I think actually that ran into the last question. So are there any others?
Okay,
no, I think. Go ahead, Dee.
Oh, thank you so much. I really appreciate, as an EDSer, all of the research that you're doing and a lot of the new information that you've brought to our attention, you know, as far as the prevalence and as far as some of the models and the hypothesis, you know, with the baroreceptor dysfunction and so forth. For me, that's something really new and exciting that I have not heard much about. So it's just very valuable information, and I thank you from the bottom of my heart, from me and all the other EDSers who are learning more from good, knowledgeable physicians like yourself.
Well, I'm glad I can be of help.
Great. Thank you very much, Dr. Neilson. It's been very informative, and we will be posting the recording and also the slides in the PDF format on our site. Our next presenter will be on August 20th. That's Dr. Pasinki. And this has been a very good session, and we really appreciate all of you attending, and particularly Dr. Neilson. It's been really informative and very educational. Thank you very much.
Thank you all.
So we're going to conclude the session for this evening, and everyone have a good evening. Thank you.
Good night.
Good night.
Good night.